Hi, I'm Jennifer Smith, and today we're going to be discussing CAUTIs, or catheter-associated urinary tract infections, and how we as nurses can make an impact to either reduce or eliminate CAUTI infections. So, again, catheter-associated urinary tract infection is just what it is. It's a urinary tract infection that develops after the insertion of an indwelling catheter. So, as many as 80% of UTIs are caused by the insertion of a catheter, staggering number, and 35% of our hospital-acquired infections are CAUTIs. So that, again, is a pretty large number. So evidence-based practice guidelines suggest a nursing bundle so that the nurses, like ourselves at the bedside, can implement these things and either reduce or eliminate CAUTIs, and they are as follows. So assessing the need for a catheter, very important. Making sure that that the patient actually needs a catheter before we even put it in. That's very important. Educating all personnel on proper hand washing. Again, very, very important because we don't want to introduce bacteria into a sterile environment. This is especially important for our unlicensed personnel. Inserting our catheters with aseptic techniques. So we all learned very early in our nursing school programs that insertion of a Foley catheter is a sterile procedure. So certainly if sometimes when the catheter doesn't go in smoothly and we have to withdraw and it touches a non-sterile surface, we can't just reinsert that catheter. We have to discard that and start all over. Very important. Providing proper catheter maintenance. So we should be cleaning the catheter site, the urethra, pericare every day, every shift at a minimum. So that's very important. After every bowel movement, we need to make sure that we are providing pericare as well because we don't want fecal matter or bacteria from the feces to travel up onto the urethra or anywhere near the tubing. Assessing the clarity of the urine every shift. Why is this important? Because we know what the signs and symptoms of a urinary tract infection are. If we're looking at the bag, the drainage bag, and we notice that it has sediment, that the urine is cloudy, if there is an odor to the urine, certainly we want to make sure to seek out the assistance of our physicians or nurse practitioners, physician's assistants, because these are all signs and symptoms of a urinary tract infection. So when we talk about the chain of infection, we can see here that a urinary catheter in the bladder can cause bacterial colonization at a rate of 3 to 10% per day and 100% over a 30-day dwelling time, and that's staggering. It can actually, pathogens can enter the urinary tract in a variety of ways. So either during the insertion, through the lumen, by manipulation of the catheter drainage bag. So it's very important that the bag's not touching the floor, that the tubing isn't kinked, that we're not dragging it down the hallway. So just the mere fact that we have this tubing there and bacteria can lay on the tubing, it can cause a urinary tract infection, inflammation, and ultimately trauma to the urinary epithelium. Why is this important? A couple of reasons. One reason is because CAUTIs can actually increase the length of stay for our patients, and obviously antibiotic therapy is the treatment for CAUTI, and that can increase either by $980 to $2,900 in additional costs to our patient during their hospitalization. And in a year, a CAUTI can add 90,000 hospital days and 424 to 454 million to healthcare costs in the United States. So again, that is staggering, a large number. Why does that matter? Because if hospitals aren't reimbursed, ultimately that affects the bottom line. Certainly, patient outcomes. One of the worst things that could happen is that our patient gets a urinary tract infection from a catheter, and now they're septic, and ultimately they could pass away. So it could have potential life-threatening outcomes. So nurses, what can we do? We want to stop the CAUTI. We want to stop it before it starts. The first thing we want to do is to assess the patient to see if they actually need a Foley catheter. This is tough because a lot of times it is more convenient for one of our patients to have a catheter than to go in every 2 hours and to change their brief, or to go in every 2 hours and change the chuck. But at the end of the day, we have to prevent the infection, and we have to provide the best positive outcome for our patients. So certainly only catheterizing when necessary. We have to, again, emphasize the importance of hand washing, proper hand washing for everybody, using a sterile technique, proper catheter maintenance, daily peri-care and after every bowel movement. And then we're noting the clarity of the urine on each and every shift. And then we are getting rid of that catheter just as soon as we possibly can. So if our patient is experiencing urinary retention, they're unable to void on their own, we give them the catheter. This problem resolves rather than being frustrated or being unable to go in and change the brief, and being unable to go in and assist them to the toilet. Say they're on a diuretic. Those are real challenges, but we need to get rid of the catheter. So that may require that we put them on a toileting protocol, and we educate our unlicensed personnel so that they can go in and help and assist us in toileting our patient. So every hospital has their own protocol for this particular nursing bundle that is rooted in evidence-based practice. There is a tool that I like very much. It's an algorithm tool, and it helps us to see whether or not a patient needs a Foley catheter. And it's a very simple algorithm. Up in the left, it talks about, does the patient meet the criteria for appropriate use of an indwelling catheter? And it gives us 10 different reasons as to why a patient may need an indwelling catheter. Example number 3 is a stage 3 or 4 pressure ulcers that can be made worse by incontinence. In this situation, we certainly would want to protect the patient's skin. It's already fragile and broken down. We don't want any additional harm to come to the skin. So this would be an example of yes. We move over to the right and we see that we are going to maintain and assess daily. And we're going to document. Very important. So using a tool such as this makes it very easy to determine whether or not they use the patient requires a catheter and when to use it. Again, we want to remove it just as quickly as possible. So it's important that we're working with our physicians, with our nurse practitioners, with our physician's assistants to get the orders that we need and to insert the catheter, and to get the orders that we need to remove it just as quickly as possible. So again, we want to make sure that part of our documentation and our assessment, we're looking for the signs and symptoms of a urinary tract infection. What are those? Those are cloudy urine, dark colored urine, concentrated urine, malodorous urine, sediment in the urine. Could be blood in the urine. We can't just assume that there was some kind of trauma upon insertion of the Foley. We want to make sure that we are doing a complete and thorough assessment and not just writing off blood in the urine as trauma. Any kind of inflammation or swelling, and any kind of pain in the abdomen noted either independently or upon palpation reported by the patient, because it could be actually a sign of a urinary tract infection. And certainly anybody working in the geriatric community knows that altered mental status is one of the first signs that our patient may have a urinary tract infection. So being on the lookout for all of those signs and symptoms is very important. Reaching out to our nurse practitioner, our physician, or our physician's assistant immediately, getting antibiotics on board, and then determining the continued need for the indwelling catheter. Thank you so much for listening, and I look forward to your questions.